Can you hear me?
We can hear you, and we can also see you. So as soon as you start the slideshow, you're ready to go.
Thank you. Well, I'm being bedeviled by technological gremlins. For some reason, my slideshow won't slideshow. So I'm going to share the screen as it is, if that's okay with you. So thank you for the invitation.
It's going well. We can hear you and we can see.
Thank you for the invitation. I'm really sorry I can't be there. It's a hard act to follow, and I'm going to be followed by an even more impressive act. But I wanted to share with you what we regard as a partial success story, and that was the health technology program that was set up at the University of Cape Town. So just to get back to here, I'm not sure if you know who the two gentlemen, bottom left and bottom right, are. Bottom left is Professor Christian Barnard, who was the surgeon who performed the first human heart transplant in 1967 at the Groote Hospital. And so that's probably a fairly popular face, and you might have come across him. He deceased recently. Bottom right, probably someone you're not familiar with, but in terms of health technology, has had a significantly greater impact, and that's Alan Komak, who was a medical physicist at the University of Cape Town in the 1960s. He developed a mathematical algorithm that was used subsequently, and he now forms the basis for a reconstruction of images in CT, MRI, PET scan, etc. And he, together with Godfrey Hounsfield, the English engineer, won the Nobel Prize for Medicine and Physiology in 1975. So those are two famous South Africans. In terms of my talk, I'm going to look at the need. So why did we do this? And look at it from the perspective of the African region, and then from the perspective of South Africa. What our response was in terms of a health technology management program, and then the flagship of the program, the postgraduate diploma in health technology management. I'll talk briefly about the execution in terms of the modality, an intervention that we had to introduce, recognition of prior learning, given the fact that most, if not many of our applicants did not meet the criteria of a university degree to enter into the postgraduate diploma, and how the program was expanded and why, and then briefly talk about the students, the impact that they had, and some of the parallel initiatives. So this is the story of Africa, and this was largely the why in the African context. Africa as a region has a disproportionately high disease burden. You'll see these are maps taken from the World Mapper project, which morphs the surface area of a country in proportion to whatever indicator is being measured. So that you can see in terms of malaria, early neonatal mortality, maternal mortality, and the two, of course, are related, and HIV prevalence, Africa, unfortunately, dominates. And yet, in order to tackle that massive disease burden, we've got disproportionately little public health spending, which is this curve over here. And then to add insult to injury, if you look at the health workers shortages, and of course that's related to levels of public health spending, many countries in sub-Saharan Africa experience great health worker shortages. So this is the backdrop, if you like, for interventions in the healthcare space in Africa. If we look at medical equipment specifically, this is work that was done, a study that was done by the WHO in the 1990s. You could also see the disproportionate investment in medical equipment when one looks at the per capita expenditure per annum. So it would be unfair to compare it to the USA, But even compared to Asia, you could see that the expenditure at that time for sub-Saharan Africa was less than 10% of what it was in Asia. And one would speculate it's not much different now. WHO also characterized problems in the developing countries. There was excellent work done over decades headed by Andrei Isakov at WHO HQ. This is one such table that came out of that work and indicated some of the impacts of the systemic inefficiencies, as they were called, and the wastages that occurred as a result of lacks of management of the total process. So if we looked at medical equipment management and maintenance in developing countries, it would be fair to say that certainly at that time, and this is, remember, this is still the backdrop to why we started the program, that more than 50% of medical equipment was not functional. And it was really a management problem or a mismanagement problem due to a number of factors, including the lack of skilled personnel, effective management tools, an inadequate technological infrastructure or enabling environment, lack of information systems and support, and a lack of what could have been called best practice within the context. So in other words, appropriate evidence-based within our context. And as the earlier slide showed, this all led to wastage and inefficiencies. There was political support also obtained in 1994 with the first resolution, RC 44 of the African region of the WHO, that for the first time recognized the importance of health technologies. So this followed a workshop, a sub-Saharan workshop that was held near Cape Town earlier in that year in 1994. And as I said, for the first time recognized challenges specifically around health technologies and the impact that they could have. Out of this resolution came actions that were directed at member states. If you look at the first two actions that I mentioned there, one was to develop a comprehensive health technology policy, and the second was to strengthen healthcare technical services that would address the full life cycle of health technology. And then subsequent to that, there were more resolutions of WHO AFRO. There's a regional health technology strategy, and there was also an excellent set of policy documents that came out of the Eastern Mediterranean Regional Office of the WHO towards the end of that decade. Within South Africa, we had, before the 1980s, we had a South African Association for Clinical Engineering Technicians. In the 1980s, clinical engineering really came onto the map with the establishment of the first clinical engineering program at the Pretoria Technikon, as it was then called. What happened in the public sector, though, there was a voluntary severance package process. And as a result of that, many of the best clinical engineering practitioners in the public sector in South Africa left, which left a huge gap. But also what started was a liaison between the Clinical Engineering Association and the Engineering Council around the issue of certification and registration. I've mentioned already the sub-Saharan workshop that was held in early 1994, followed by the WHO AFRO resolution. And then significantly also was the launch of the African Federation for Technology in Healthcare, which burnt brightly, but sadly all too briefly. So by 2000, the funding that had supported AFTH came to an end, and the AFTH became dormant. But the AFTH actually was a strong supporter of the program and provided the initial funding that enabled the HTM program at UCT to actually commence. Also importantly, in the second half of that decade, there was a health facilities audit conducted of all health facilities in the South African public sector. There were two conferences that were held, Medic Africa conferences, at which a number of the issues were raised, both for the region and for South Africa specifically. There was a national steering committee on medical equipment management and maintenance that was set up, that submitted a report to the national. And all of these, in a sense, aligned with a need to have a program that would respond both to the African context and to the South African context. And that's really where the program...
We've got about 5 more minutes. About 5 more minutes.
Pardon?
About 5 more minutes.
Sure. And then also at the same time, there was increasing investment in the public sector, specifically in the area of clinical engineering services. So a need emerged then also from the private sector to actually have a capacity building opportunity. So what I'm going to do then is gloss over some slides. I can always return to them in question time. But we took our mandate from this brief, but I think powerful definition that health technology management is optimizing the acquisition and utilization of healthcare technologies to achieve maximum beneficial impact on health outcomes. Now, those are all loaded words and should really be unpacked. We also recognize the interdependency of healthcare, technology, and management, and built into the program content and discussions that would actually address that interdependency. To provide a brief kind of synopsis of the program, as mentioned, it was launched in 1998 as a unique response. The activities that were envisioned including teaching, research, advocacy, and networking. As mentioned, the postgraduate diploma became the flagship offering. There was a master's both in science and philosophy program. There were a handful of students that did those. The PhD program never got off the ground. The emphasis, as I said, was context-sensitive capacity building. So we tried to engage with the students so that each student felt that their needs coming into the program were met, or their expectations were met, and that going back, that they had a good sense of what they could do, having been exposed to the knowledge, the skills, and the networking and the experience of colleagues, that they could go back and make an impact in their own environment. We started off initially with a 10-week on-site block, but it quickly became apparent that that was not sustainable. And in the end, we ended up with a 2-semester module with a 2-week lecture block and a 1-week examination block in each module. This is the second group of students. The first was in 1999, which had 4 students, 2 from South Africa, 1 from Tanzania, and 1 from Mozambique. This was the class of 2000, and just to emphasize what we tried to do within the group, there was 1 nurse, there was a radiographer, and there was a hospital engineer, and the rest all came from a clinical engineering background. The courses that were offered, you can see the top section describes the courses that were offered initially as part of the initial offering. In 2010, we expanded the offering to include health facilities and asset management and related topics. So the ones that are in darker gray were added in 2010. And then more recently, health informatics and management information systems and medical device innovation were added. So what we hope to do with this program, with this offering, was to actually provide a grounding for the assessment, innovation, management of healthcare infrastructure and technologies, with a firm focus on improved quality of care. We also had a linkage with Northwestern University in 2006. We established this global health technology study abroad collaboration, and that exists to this day. That also fed into the HTM program and was fed by the HTM program. To end with,
so we need to
conclusion.
Wrap up. Need to wrap up
Yep.
when you can.
Yep. What we've learned from the program, first of all, that they say that governments are bureaucratic and government machinery moves slowly. Well, what we concluded was that universities have perfected that art. And it was incredibly difficult to convince the universities of the benefits and the returns on investment of offering this program via distance learning. So in that sense, the full potential of this program was never learned. On the application side, what we've tried to instill into our students, that ultimately this is about responsible asset management. And you can see the definition there that is provided by our National Treasury. It's about maximizing the service potential of the assets that have been entrusted to us. And so this still remains the mantra of myself and people who are in the program. I continue to meet the students. Many of the students that came through the program are employed in provincial health departments in South Africa and in other countries. And I met a number of them at the Africa Health Program last week in Johannesburg, and they are still fighting the good fight. Thank you.